it's muted throughout the session to ensure that decorum as well. Thank you very much for your active participation and also compliance with the virtual meeting decorum. Thank you very much. So moving forward, thank you. So we'll move on to the fireside chat. And for the first question, Emeka, we would like to know what initially inspired you to focus on interoperability within Nigeria's healthcare system, and why is it such an important issue to address today?
Yeah, thank you very much, Udina. And this is a loaded question, really, because from a personal perspective, there are multiple motivation, and my motivation change as the years go. So I will start from my initial motivation, and then I will move forward to how they change. Initially, I go to conferences. Again, at my career in digital health is such that I have the privilege of going to digital health conferences, both within and outside the country. And for each of this conference, and this is like over the last 2 decades now, but one thing has been consistent, that each of this conference, people talk about interoperability for half the time. Some of them far more than half the time of each of these conferences. And for me, I felt like why, and initially it felt like the problem of interoperability was solved. But then as I go to more and more conferences, I'm realizing that I'm seeing then that, wait. This is the same thing we talked about last year, and it doesn't seem like it's happening. But again, and I then decided, I thought this was an opportunity area to make a mark. So I took a keen interest in it, but of course, there was really not a lot of opportunity. I didn't have an interoperability project to work on, so there was not opportunity, but I had interest in this area. And sometime in 2014, I had the privilege of working for the Nigerian government, where I was in the Ministry of Health, and then I had a bird's eye view when we were working on the national strategy to see where interoperability fits, but where the different technology system fits in the national system. So having been somebody who worked on one technology product, now zooming out and looking at all the other products and where they all fit, then I knew that there was a need to figure out this interoperability problem. Also, that opportunity also affords, I saw the fact that at that time, there was really nothing like interoperability, even though if you're working individually, you would think there are. But then when you look at the whole, you realize that it wasn't happening. And then I also, because I live in Abuja, had the opportunity of working with the colleague who heads eHealth at that time in FCT. And he was leading the 14 general hospitals EMR deployments, and even the EMRs that were deployed by the same vendor in multiple general hospitals were not even sharing information in any way. They were not designed to do that. So we started trying to solve the problem, reach out. Of course, with our limited knowledge, we didn't go far. And at that same period, I got the opportunity to do my PhD. And of course, this was an opportunity to say, yes, this is the thing I want to work on for 4 years. And then I decided to invest much time. Then before I left for my PhD, because this is a problem we're already trying to solve, we said, okay, let's start DHIN, because we were also keeping an eye on how the banking sector solved this problem. And we saw that, okay, they created needs, and it's not something that one organization can do. So we decided, okay, let's form an association that can bring together many of these different vendors to solve this problem. And of course, many things has happened between then and now. So those were the initial inspiration for me for starting this. And then we called colleagues together who have the same interest, the same pain points. And that's how we started a conversation. And that's how, of course, having gone to study this for 4 years, it then became a lifelong passion.
Thank you very much for sharing your experience with us. And, listening to you, and a couple of things stood out for me, which is the part where you talked about zooming out and seeing things at a high level. And I think that's very, very important. It's very crucial that, as health system leaders, that we think about the problems that we are trying, the healthcare challenges and the problems they were trying to solve in healthcare from a systems level, because we are not just trying to solve a unit problem, it's a system problem. So we need to think about how the solution we are trying to provide for a particular problem impacts the broader healthcare system, which now helps us also think about building that enabling environment through interoperability to foster that ecosystem for the digital health implementations and adoption and scale up that we all hope for. So thank you very much for walking us through that and how your interest has evolved over time. And moving forward, would like to hear your thoughts around what are some of the primary challenges Nigeria faces in achieving interoperability within its healthcare systems.
Yeah, I think I will start from the value that interoperability brings, because it seems many stakeholders struggle with clearly identifying the value that interoperability brings. And while everybody can talk about the need for interoperability, there are very few that can properly articulate what value it brings. And I'll go back to last year I was working in Lagos, and a tertiary hospital was narrating how they have an electronic medical record, a very successful electronic medical record system that was offline. And for me, an advocate of interoperability, listening to the actual user who cannot seem to find a need to invest money in making sure their system is connected to other systems externally, and the main reason for digitization they have achieved. And for them, the additional value that interoperability brings is marginal. And of course, that's something, and again, that's an example. But many health sector leaders, especially at the national level, seem to drive the conversation of interoperability from just the public health value of collecting data and making sure there's seamless data. But of course, interoperability goes beyond that, because continuity of care, you will make sure that the patient is better cared for if their health data is not fragmented and distributed across different locations. There will be better use of resources, reduce wastage when these values are clearly articulated. But again, that's not where the argument comes from. So the value is not often well articulated by the people advocating for interoperability. Now, in terms of what is the challenge that comes, that is the reason for interoperability, I would say we can start first from, I think some people will call it vested interest. Different vendors have considered their data, I don't know how to put this. So consider their data strength as, no, let me rephrase it. So vendors consider their strength by the amount of data they have and the amount of data they're able to control. And traditionally, when you design an interoperability system, it is supposed to be a centralized system to be managed by an organization. And each vendor quietly and secretly nurses the idea of being that interoperability provider, because each time the interoperability provider automatically has a lot of power over all the other vendors. And then how would another vendor X allow vendor B to be that power broker and holder? So because of that, it doesn't even happen. Of course, there is the problem of technical expertise to actually design and implement this interoperability problem. But the biggest problem is inter-vendor rivalry. And there is also the poor digitization practices where digital systems are just designed to either solve the money collection problem and not really clinical problem. And as a result, this creates a problem when either the regulators or the policymakers comes and say, hey, let us interpret your system. Or even if the hospital authority decide down the line after the fact to interpret their system, they struggle because their system was not designed initially from start to be standards-based. And of course, at the country level, it is not clear what standard they should follow. And I mean, of course, these days you hear people talk about, oh, let's use FHIR standard. But again, even if you use the same version of FHIR, there is no guarantee. In fact, there is guarantee that if two vendors do not talk to each other and they use a certain version of FHIR, their system will not integrate. It is guaranteed, that I know. So the challenges are enormous. And of course, the funding constraint is there, but I don't always like to bring funding out of the conversation because the bigger problem are the ones, I put it in the order of the problems as they arise. So I would say that the challenges are enormous. And what is important is let's create an environment where we have these kinds of conversation so people know the need to address these challenges head on, because people don't generally want to talk about this problem where there is vendor rivalry. But in the US, they talk about it because they create policies around information blocking, and there is fines for vendors who block information. They've tried to address it, but they've not even been able to fully address it, because you try to address it in one way, it raises its head in another way. But I mean, I can talk about this on end, but I want to pause here because the challenges are enormous.
Thank you so much for that wonderful piece that you shared with us. And listening to you, a few things that came to mind while I was listening to you. You mentioned keywords around continuity of care and fragmentation. You talked about value proposition and articulation from the interoperability advocates component of things. Then you talked about data ownership and interoperability, right? Which now leads us to vendor rivalry, right? Which is a very beautiful thing to look at, because when we talk about interoperability, we don't just talk about standards like you've talked about, right? It's not just about standards. It's not just about following a particular protocol or or process of designing a particular system. There's several other things. There are several other co-founders involved that are impacting the challenges that we see when it comes to interoperability. And I would just want to, if you could just throw a little bit more light around data ownership and interoperability, and then the rivalry parts that you talked about. So you said that vendors kind of weigh their strength based on the data, the amount of data that they have. Why do you think that is so? Is there something else from your experience that you think that could be done to kind of help shift that mindset, that paradigm, to have that paradigm shift from that view of our strength as the data for vendors and seeing it as a collective effort, as a collective initiative to help us achieve or arrive at, that echelon of, a broader integrated, healthcare system that we all hope for in this case?
Yeah, your question. Yeah, thank you very much for that question. As you were articulating that question, and a few examples come to mind, and I'm going to share. You have a vendor that has 1 million patients that they've curated over multiple years, and they manage them. And you have another vendor who has 40,000 patients that they are managing. The value that the vendor that has 1 million patient brings is not the same with the value that the person that brings 40,000 patients to an interoperability conversation. And so I wouldn't want us to go the route of saying that or thinking that there is some kind of legislation that government can do, or that we can legislate our way out of it to mandate the vendor that has more patient, or just make sure that I think it has to be a consensus building mechanism. I think my thought is that it has to be based on incentives or transaction-based model where you earn by your contribution to the system, and there are many models that we can think about. Unfortunately, there's not a lot in published literature, because this is an area I researched significantly around. Going back to my earlier argument that centralized systems are the systems that we know. And my PhD was based on decentralized system, the blockchain-based system. But I don't want to bore us on decentralized system. But the reason why blockchain is introduced in that blockchain is considered as an intermediary for sharing information is that the way it works is that you can have multiple stakeholders own a data that is on a blockchain without one person laying claim to the ownership. And they'll just simply use their signatures and execute some contracts for sharing and transacting on that blockchain. And with that, you can design some token-based model where each person will benefit from it. Again, this is currently happening, but it's mostly happening. I mean, in the last 3 years, there are new blockchain models that has sprung up in the Western world where many are already experimenting on this in the financial sector, in the health sector, for this same purpose. But traditionally, you would have a few hospital networks come together and say, hey, let us band together and create this organization. And they will use that organization they create to then manage that centralized system. Just like what we have in NIBS, where the banks in Nigeria come together and created NIBS, and they use NIBS to manage information sharing between the different banks. So if you're transacting from an account in GTB to another account in GTB, they do it internally. But if you're transacting from GTB to Access Bank, you need an intermediary. Because even though these are reputable banks, you need a way to make sure that there is no deniability of transaction. There is somebody who can intermediate between one bank and the other. So what if you send ₦1 billion from GTB and GTB say, oh, our system has left, Access Bank, even so that's why you don't have an API between GTB directly to Access Bank. There needs to be an intermediary that then receives that money and clears it into the other bank. And this is how it works in the financial. This is also how these centralized systems work in developed economy. So vendors will not trust other vendors. Even smaller vendors will not trust the bigger vendors to just share their information if they do not, because then they are strengthening the power of the bigger vendor. The bigger vendor will definitely not trust the smaller vendor. So we just have a stalemate. The only way is where they can trust each other is if they have a data sharing agreement, they create an organization amongst themselves, or there's just any intermediary, or it could even be government. Create an intermediary and legislate that everybody comes through the intermediary. But we know even government in the Western world do not have the capacity to create these things. The best they can do is they will create a sandbox. But then governments generally don't run technology system. And so it now means that vendors may have to band together, create an organization or create a system, agree, have a data sharing agreement, and then move forward with it. Of course, we have other problems around digitization in the developing world, which I think is a bit controversial. Let me leave that out for now.
Yeah, true. Talking about that, of course, there are still challenges, right? It's not just when you talk about interoperability, it's not just the challenge that is domiciled in low resource settings. It's something that even the high-income countries or high-resource settings as well still experience those challenges. Most especially when you talk about like legacy systems that maybe may have implemented or designed their systems at a time whereby conversations around interoperability and integrated care weren't, as prominent as it is at the moment. And you mentioned something. Two very beautiful points I would like to highlight here, where you talked about collaboration. So from what from what I'm hearing collaboration, vendor collaborations, right? So, and you also pointed out, you mentioned government, playing a certain role in this case. So which leads me to the next question here about, what role should government regulations and policies play in driving interoperability?
I believe government needs to set the enabling environment for interoperability to thrive, meaning try not to be overly involved in implementation because they will not do it well, is the truth. So no matter how hard they try, it's always better to just allow the private sector and the development environment to drive that. And government in developing countries should not see the private sector as enemy and only the thing that comes from the development sector is what is working. No, private sector is doing an amazing work. Actually, some of the scaled systems I've seen in Nigeria are actually systems that are coming from the private sector. And governments are actually putting their money in those systems. So it may be that we may need to rethink that maybe the development sector should also look at what the private sector is doing in Nigeria because it may help. But going back to what government, yes, government can set the national strategy and state level strategy for how to go about digitization and go forward with implementing it with the relevant operational plan. But they need to put money in having at least a few people at the state level, like a situation where a whole state does not have anybody who understands digital health means that charlatans will just come, send them a proposal, and they will just adopt it because there's nobody to help review it. Nobody is knowledgeable enough to even understand what people are talking. So they need to put 2, 3, 5 people within the entire state that should even be able to read proposals and interpret it, pay them well, because the opportunity cost of what they are losing is bigger than the money they could pay these people at the state level to do this. So that's a critical missing point. So we've developed multiple. You have very few people. You have just 1 or 2 persons who are doing digital. How is that even possible for a country of 200 million? This is not possible. So we need more people in government, and it's not a show that only the Ministry of Health will do. Of course, I know I'll get in trouble for saying this, but I will continue to say this. You must bring Ministry of ICT into these conversations because you need the expertise, you need the advice, you need the guidance. You must bring private sector people who are actually doing this thing to support and provide the guidance, because it's not a Ministry of Health only thing. Of course, if Ministry of Health has all the knowledge, fine, but yes, in practice, they don't. So it's something that they need to think about. I don't even think that the Ministry of ICT in most of these places, not just in Nigeria, are the enemy. I think it's just they need our help and they should just reach out for the help. And the private sector, obviously, very important. They will help them set the right policy. The argument I keep making most times is that, yes, if you do not bring in experts when you are setting policy, you do not even know what you are setting in your policy. The policy is going to be useless from start. So they need to bring in the people that know what they are doing to help them do the work.
Great. Thank you very much for that response. You mentioned something around, from what I'm hearing a bit of a private-public kind of collaboration to help foster interoperability in this case. And, you've also talked about the government role as well as, for implementation of the digital health enabling environment for that digital health ecosystem. Moving forward, just also trying to be cognizant of time. From a technical standpoint, what are the essential elements needed to integrate diverse health systems in Nigeria?
From a technical standpoint, I would say capacity is one. And then this capacity is, let me just break down before I go into the components. The capacity of the technology people to understand the domain, the healthcare domain, is a big issue. And then if it means that the healthcare domain expert needs to understand technology, but these two knowledge needs to come together in a way, or at least they should be in the same room in a way that it will help drive progress in interoperability. But the components that you've talked about, there are many different components. Again, we often talk about data dictionaries for terminology system. We talk about health facility registry. We talk about health workforce registry, the identification system. These are different components, but they are not single system. They're not monoliths in the sense that you understand in Nigeria, the governance is decentralized, meaning that you have a health workforce registry in Abuja does not mean it's going to just operate automatically across the country, because you then need to have smaller ones across the states. And so you need to factor in all of those changes. And then even when you don't have health workforce registry, in the health sector, we also have many different regulators, the doctors, the nurses, the CHUs, the pharmacists, different, and there are regulators by law. So you cannot then say you build this giant system and then you force everybody in. And that's why we have had health facility registry, workforce registry, and the likes that has not been used. They would be there after the project that funded it dies. The thing will just remain moribund. And then I keep making this argument of these registries. It is not delivering the registry that should be a measure of success. It is by how many times is it being used. That's my measure of success of a registry. If it's not being used, then it's as good as useless. So we should start measuring success of healthcare registries by how much it's being used, whether it is the national identity system, or if they decide that they will use a master patient index, or if it is a terminology system. Let's find out how it's being used. That's what is most important, and what will help us look at where the problem is, because right now it doesn't seem like we're looking at where the problem is. Of course, we also have standards that are not also being used. So use seem to be the problem we are having, while looking at all these components, which we've already identified. The different architectures globally has identified that these component areas, once the system have these component areas figured out, then you will easily integrate your information system. Of course, integrate and interoperability. I know somebody listening to this could then take me up on, oh, integration does not need interoperability, and does not need some of this registry, while interoperability needs this. But let's not confuse our listeners. I just want to point that out.
Sure. Thank you very much. Very great submission on that. I love the arguments that you're making around use, right? It's not just about having these standards in place, right? It's about how much, to what extent are they used, right? To what extent are they put into practice? And I love the arguments that you made, the first argument you made about capacity, right? You talked about capacity. When you talk about capacity, you also mentioned that in the previous response as well, in respect to the role of the government, where you're talking about the ICT, Ministry of ICT and the Ministry of Health, right? And which, I mean, it's foundational. When you think about the digital health space, you think about the health informatics space, or you think about the health information space, right? It's an interdisciplinary space. It's a multidisciplinary space. So it's not something that a single discipline or a single domain can get the work done. So we need both the domain experts who are the healthcare clinical, those who have the clinical or the healthcare background, and we need both the technical experts as well, who have that technical acumen and understanding to help drive the innovation that we need. And, it's beautiful that you mentioned that, because that's like, for those who are at the start of this session, I gave a bit of an introduction about the host organizations for this session, Healthlytic and the VC HealthTech Hub. And the VC HealthTech Hub also provides those capacity building strategies and also resources for healthcare workforce within Nigeria and across Africa. Moving forward, just being cognizant of time as well, what types of skills and competencies are required in the workforce to drive interoperability in Nigeria?
So there are multiple layers of skill that we need. We need a traditional software development skill. We must call it out. It's very important. But we also need the skill to properly specify what these software developers will be building. That's two. And of course, if we say, okay, to specify what they'll be building, things like what terminology standard is going to be used to manage which disease domain area, whether it is diagnosis or it is drug classification. So, and you have myriads of standards that you can choose from. So one has to sit down with a group of stakeholders and make a decision from cost, from licensing, from many different perspectives, which set of standards, which terminology system will be used. And of course, then, okay, which syntax of standard needs to be used. And all of these are skills that either you learn in training, in meetings. There needs to be environment that this conversation happens, the practical interoperability, and that conversation is not happening enough. So you hear people talk about interoperability. In fact, many of them advocate, let's use FHIR, but okay, what does it mean to use FHIR? Okay, let's actually move forward to using it. What does it mean? And then, so those skills are necessary, and we can acquire it through training, but also through actual conversation, practical conversation around interoperability. Of course, we cannot dismiss the place of health informatics training. There needs to be a career path for health informatician. There also needs to be training for health informatics for the in-service training for the traditional health workers, whether they are doctors, nurses, CHUs, in their training program as they come out of the university. We need to infuse it. As of last year that I worked on this, it's not yet there in Nigeria, and it's not yet there in many African countries. Actually, from the Global Digital Health Monitor data, we know that there's not a lot of that. Sorry, there's noise around me here. We know that many countries do not have in-service training for their health workforce. Of course, sorry, not in-service. I was going to say pre-service training before they graduate. The in-service training that happened, many of them focus on DHIS2. Again, that's an area. DHIS2 is just aggregate data collection, has nothing to, of course, it has a lot to do with collecting the surveillance and how service delivery data is happening at the different locations.
Regional.
Yeah, but again, when it comes to actual interoperability, there's little we can say DHIS2 can contribute to. But of course, again, that's what we have, and we just have to advance that. And I think that's why the conversation is always focusing on DHIS2. So that's the only in-service that happens now. But of course, a few orders for deployed services, but it's not happening enough.
Thank you very much for sharing that. I really love the way you brought in part of what you mentioned earlier about, you talk about capacities, you talk about, the ground or foundational skill of like software development, and then the specification as well, which is also part of like, specifying what terminologies, what standards, what interoperability standards or specifications that would be used or that would be guiding the software development that the software developers would be making in this case to help drive that scaling of the digital health technology once it's been designed and deployed, right? So moving forward, for the last question that we have for the fireside chat, before we now go into the chat box to see what questions our audience have for you, what are your long-term expectations for Nigeria's healthcare interoperability journey, and where should efforts be focused in the next 5 to 10 years?
My long-term expectation is that we will break the jinx and we will interoperate. I know the traditional conversation has always been that government will lead. It will be wonderful if government can lead this. And but again, I hope that it's not going to be based on legislation, because it will simply not work. But as long as it's based on consensus I'm very hopeful that we are going to move there. But even if government slows down, there's a lot of conversation happening now that even if government slows down, there's a lot of private sector coming together that will catalyze things and move it forward. And mind you, there are a few interoperability that's already happening in the country. Not that like there's nothing happening at all. A few vendors are already integrating their own system. When we talk about interoperability being a problem, it's actually mostly multi-vendor interoperability. That is where we think the problem lies. So, but we believe that will be solved as long as the financial models are clearly defined and there are models for executing this in code. Then it's going to be easy to move forward. And I think that the government will have a significant role in setting the policy direction to make this happen, but also let it, I think where things may get muddled is when government tries to implement. That's where it becomes a problem. But as long as government guides, then they won't have an interest. And again, the example is what happened in the NHIS, National Health Insurance Scheme, where government tried to implement for many years until just last few years ago, they realized that, oh, they cannot go forward with this failed policy. They had to decentralize to the states. So I don't want them to make the same mistake where they think they would implement, and then after many years of turning around, they realize that, oh, we need to give this out and just regulate or provide a policy environment. So yes, my expectation is that things will move forward. And we can start from integration of aggregate system, very easy to do. You don't need a lot to move in that direction. I actually think government can lead in that direction. They can actually implement those to help them with their surveillance information. Then layer two, we then move, I think in parallel. It's not like they're mutually exclusive. It can be done in parallel where stakeholders will come together and really figure out interoperability standards and how to make it work. And I think it will work.
Thank you very much. Thank you very much for sharing that. And that brings me to the end of the questions that we have for you for the fireside chat. But we'll move into the chat box right now to see what questions that our audience have for you. And just to give a bit of a context about how this will be done, we had received a couple of questions from the registration form, 3 questions that were sent in. So we have 2. So I'll try to take one of that and one from the chat box right now, and then the other one from there and this from here, just so that we can be able to get to the questions more evenly. And just to assure our audiences that we'll try to get to as much questions as possible, but just to be sure that we don't overburden our attendees by keeping you guys longer than we planned for, we would address the ones that we could address on this call, and those that we can't get to, we would curate that and share that with our speaker here, Emeka, and Emeka would provide us with the responses, and we can share that with our audiences at after the session via email. So for the first question, how do you propose medical students in Nigeria can learn about healthcare data interoperability at scale? Then just for context, the person mentioned that it's scary how much technology goes into healthcare data interoperability and how blindsided students are about it. So how do you propose they could learn about this at scale? Sorry, you're muted, Emeka, if you're speaking.
Ooh.
Yeah, okay.
Oh, thanks. Sorry about that. I would say there are multiple parts to it. One is to join conversations like this, whether they are local conversation or global conversation, attend connectathons, whether they're hosted locally or globally. HL7 regularly hosts those. Actually, a connectathon is a good place to learn. But beyond that, it may also come out really technical. There are very good books that I would recommend. I have one here. Principles of Health Interoperability is one of them. Principles of Health Interoperability by Tim Benson and Graham Grieve. Graham Grieve is the original author of HL7 Fire, before it was then adopted by the community. That book is really, really good. It's not the only book, but that book will help to break things down. It's a bit technical, but it's easy for non-technical people to also grasp. Again, I'm not saying that anybody who is from a health background will understand that well, everything in that book, but a good part of it will be easy to navigate. It comes from the history and the value proposition and all of that. There are, of course, understanding, joining, just following digital health in general. Volunteering for digital health projects would be a good way to start. And just if you have an interest in that area, I wouldn't say jump to interoperability automatically, but start from digital health projects. And then that would be a good way to then see the value of interoperability.
Thank you very much for sharing that. You mentioned a couple of things that are very important to you. I would just like to highlight for our audience here and just do a little bit of a plug. Emeka, you mentioned Connectaton, which is either being offered by HL7 or IHE, that's integrating the healthcare enterprise. But at the same time, I would also like to notify our audience here that within Nigeria as well, the DHIN, that's Emeka's organization, also offers or organizes Connectaton. And I remember they organized one say roughly around this time last year, if I'm not wrong. So yeah, so that's also one way you could also attend the Connectaton without having to be worried about the international cost of attending those from the HL7 or IHE. And we talked about capacity buildings as well, right? So I've mentioned that earlier. So thank you very much for sharing that. And moving forward, the next question was around someone said, brilliant analogy to financial services gateways and clearing houses. There's been very few, if none, equivalent in the health sector, possibly Rwanda's model. So the question is, what would that clearinghouse look like, and who would pay for it? How do we avoid building infrastructure that can't be supported?
Very wonderful question. And this is the biggest challenge we are having. Especially in the digital health space on the continent in Nigeria. I don't know the details of the Rwanda model, but I can assure you that if that Rwanda model is paid for 80% by the donors, then it's going to fail. Because as soon as the donor money goes, it will not stand. And that's where we need to start. Again, I'm not advocating for donors not to pay, but I'm just saying that we must keep an eye on sustaining these things beyond the donor funding. So, and that comes to the question that was asked originally. How do we make sure that we do not build infrastructures that do not have support? Again, we have technology infrastructure on the continent in Nigeria that runs. The base stations that the telcos run, they run without government support or donor support. The financial sector have infrastructure that run without government support. One can argue that, the financial sector has a lot of money to manage this technology infrastructure. But I think the money is less of the problem than the sustainability model. So when one person pays for it, or people who are not the direct beneficiary are the one paying and managing it, paying for and managing it, then it's not going to, from my experience, those kind of systems, as soon as the project goes, it's just a month after the project ends, it will just die off. Because first, there will be the expectations of payment for salaries, for running the system will not be practical. So as soon as that donor or money or that project ends, it just dies. But of course, there's a model that we can work where the donor money can be used to catalyze this system with a good business model in a way that it is properly priced, the running of the system is managed in a way that it is sustainable. Again, I know this is a loaded word, sustainable, but again, if you are spending 1 naira on a system that is generating 90 kobo, then you know it's not sustainable. You need to figure a way to spend 7 naira so that when it generates 90 kobo, and then figure new ways of making money from the system, which as soon as you have clean data, there are many new ways to make money. You can generate new services for the clients on the system. There are just so many ways to make money out of this system. And there are many people who are looking for clean data out of Africa, and they're not seeing it. So, I mean, that's my thoughts. Again, seeing examples of interoperability systems that have been built, but they are just built around the money that is funding it. And after that money goes, if, for instance, you see an interoperability system that is built around HIV/AIDS, it does not even consider malaria or that. It just focuses, super focused on HIV/AIDS. And then after the HIV/AIDS money goes, the project just dies out. And again, it may be a wonderful project, but if it is not built to be sustainable, it'll struggle. I know that this is not a popular opinion, but I mean, I'm not trying to say what is popular. I'm trying to share what I think will solve the problem.
Thank you very much for sharing that. You have a very strong point on that in respect to like the sustainability component of things. Without further ado, I would just like us to briefly touch on this one more question before we call it a wrap. How will AI tools change the way we interact with health data, and how will health data change as a result of AI?
Yeah, I mean, this is a question. So one can rephrase that question to say, what is the role? Why do we need standardization and interoperability if AI can help us do many of these things? Actually, AI can traditionally decipher insights from natural language stored data. Why do you need to structure the data if AI can just discover insights from the data? I feel like AI will perform better if the data is standardized, and then you now couple it with the natural language or natural data presenting in a natural language format. So like you write it out as a text, it's not structured, it's not standardized. AI can help in that area, but it doesn't mean that if you have a system that is not standardized using AI, and you have another system that is standardized using AI, the one that is standardized using AI will perform better than the one that is not standardized at all. Again, there are so many reasons why this is so. But of course, will a system that is using AI that is not standardized, perform better than a system that is not using AI that is not standardized? Yes, AI will decipher insights from non-standardized, non-structured data, and this is where we are headed. But again, of course, there are pitfalls to that because AI is supposed to recommend from many of the best practices of use of AI. We expect that AI systems should just recommend and not make the decision. But again, there is a strong tendency, and there's a research I read recently actually, where the doctors were following the AI advice blindly, despite being professionals themselves. They were not like second guessing or rereading what the AI was providing, anything. They now, initially, it was supposed to be an advice. Then down the line, after many times of using, they now started to take everything to the extent that when the AI then makes a mistake, they are not acting as a human in the loop. The whole problem just flows in and goes into the system. And those are the kind of errors that we are going to see. Of course, the way we are now, where we are, there is also human error from traditional physicians. Of course, we've not studied that. I'm not a doctor, but I know that in the US, the study shows that the error rate is actually really high. In developing country, of course, you can imagine what that would be. So AI may be performing better than there's no research to that. But there may be, I think there is a study that is showing that AI perform better in the developed world. So the tendency to just blindly follow AI will be there. So AI can help, and there is a lot of ways it can help. So I'll stop there.
Oh, thank you very much for sharing that, and that's a very beautiful submission on that. And just to add to that conversation is just about when you talked about the human errors and humans blindly following AI's recommendation. I think that's where you talk about automation bias in AI. So wholeheartedly or 100% following the recommendations from an AI model in this case without thinking about other components of that are involved or trying to understand, then you now think about explainable AI models and all of those things. So, but we have to wrap up right now. We see that we acknowledge that there are a couple of more questions on the chat box that we can't get to. But like I mentioned earlier, just so we don't overburden our participants in this case, we would move forward with wrapping up with the session. And at the end of the session, we are going to curate those questions and share them back with Emeka, and he'll provide us responses to that, which we can share with our registered attendees via email in this case. So thank you very much, Emeka, for your time and for sharing your own wealth of experience and knowledge with us. We really appreciate your time. And I believe just like myself here, as every other person here, we have learned so much when it comes to interoperability, trying to understand the challenges that that we face with interoperability and achieving that integrated care model that we all hope for, such that we are easily able to have like a better health outcomes in this case. So thank you very much for sharing that. And we look forward to also connecting with you. Moving forward, could you share back the slide? Again, thank you.
Thank you very much.
So moving forward, yeah,
Yes.
thank you very much, Megan. Yes. Moving forward, we'd just like to highlight our supporting partners. Like I mentioned earlier, the Innovate Health Africa, Digital Health Africa, and Medics in Tech, who had supported us throughout the promotion part, the promotion for this event. And we have just one minute for each of the organizations. So we'd just like to confirm, do we have a representative from Innovate Health Africa present here with us? If you are, please move on to the next slide. Okay, anyone from Innovate Health Africa? Yeah.
Yes.
Okay. Oh, great. Yeah. So you just have 1 minute, just to for thank you very much. Carry on.
All right. Thank you very much, Mr. Obina. Good evening, Oluwatobiye. Big shout out to Mr. Emeka. Good to see you again. I just want to say big well done to everyone, VC HealthTech or Healthlytic, for putting this together. I mean, as part of the commemoration of the Digital Health Week 2024, we are happy to support what you are doing. I mean, I have just 1 minute, so I don't really know, what to say. Innovate Health Africa, of course, is an organization contributing to the whole conversations around digital health transformation going on in Africa. We have our website right there, our profiles on LinkedIn, our email. Just in case you are looking for partnership opportunities, you want to support what we are doing, and you want to benefit from the things we do as well. We have a couple of initiatives coming on. The African Healthcare Innovation Fellowship 2025 application will be opening very soon. And of course, these are opportunities you can take. Also, we are currently recruiting for talent in different areas. The applications are up. You can check our website, our LinkedIn profile as well, to see where you can work with us. Of course, also, if you're looking for partnership opportunities and exploring different ways we can work together, just send us an email. We are very much open to that. Once again, thank you very much. And it's a very great privilege to be part of this. Have a very great weekend ahead, everyone. Thank you, Obina.
Awesome. Thank you very much, Oluwatobi, for sharing that with us. As we mentioned, Innovate Health Africa are part of our supporting partners, and like they mentioned, reach out to them for areas to explore synergies. And we'll be looking forward to a representative from Digital Health Africa. Anyone present? Do we have a representative from Digital Health Africa with us? Okay, so we'll move forward with the next segment. So Digital Health Africa are part of our supporting partners, and as you have on the screen there as well, you could see their websites, the link to their websites, their LinkedIn profile, as well as the email address, in case you are looking forward to explore areas for synergy or be a part of the digital health conversation going on with their organization as well. So that's one way you could reach out to them. Moving on to the next slide. Great. So do we have a representative from Medics in Tech here with us? Okay, so no problem. So Medics in Tech as well are also part of our supporting partners, and have also supported us, as well as the two other organizations that I mentioned earlier, in the promotion for these events. And as you can see on the screen, their contact information are there, and you could reach out to them for the partnership, or also exploring areas for synergy. Without further ado, we just move on to the next slide. Great. So here is the second session that we have, that's Healthlytic and the VC HealthTech Hub are co-organizing for the Global Digital Health Week. And we were also supported by our amazing supporting partners, Innovate Health Africa, Digital Health Africa, and Medics in Tech. And you can see on the screen here, you have links to the registration form. If you not registered for that, you can do well to register for that as well. We have amazing lineup of panelists, Professor Arinola Joda, and we have Dr. Victor Dumuyiwa, who will be talking about the topic, who will be sharing more about building a digitally enabled healthcare workforce for Nigeria. Next slide, please. Great. And lastly, here we have the contact information and the website link for Healthlytic and the VC HealthTech Hub. So do well to reach out to us by email, or you could also reach out to us on LinkedIn or any of the social media handles at Healthlytic on LinkedIn and Facebook and Instagram, and also at the VC HealthTech Hub on LinkedIn and Facebook as well. That being said, before we wrap up, or call up my colleague Izine to give a closing remark, I'd just like to mention that at the end of this session, we will be sending out an email with an evaluation form just to gather feedback from our attendees. You could share your thoughts with us about, what you feel, how much value you felt you received from today's session and the conversation that we had with Emeka. Are there also areas for improvement? Are there also additional topics or areas that you'd like to hear further discussions on? You can do well to include that in the evaluation form with us, and I'll be handing that over to Izine.
Hi, good evening, good afternoon, good morning, everyone. I've been over your journey from. Thank you so much, Obina and Emeka, for an amazing session. The comment session has been buzzing with so much insight that has been shared. And I think this is a conversation that we'll keep having till we get things done, and it's going to be a while, and we know that. So thank you once again for your contributions, our partners. Thank you so much. Those who have stayed to this time, I know we stayed like 10 minutes longer than we're supposed to. We really appreciate you. And please sign up for the session tomorrow. I'm going to put, you can go to our LinkedIn profiles. You're going to see the links to the event for tomorrow. It promises to be a very amazing one as well. If you've enjoyed today, you're definitely going to enjoy the one of tomorrow. So please sign up for that one. And with that, I'm just going to say thank you once again, and you have an amazing day. And we'll send the videos, the recording out to you in due course, and the evaluation form, like my colleague has mentioned. So Obina, thank you for holding this together. And Dr. Meka, thank you once again. And everyone who has attended, thank you. And have a nice evening or afternoon or morning. Bye.
Yeah, thank you
Thank
very
you.
much, and bye. Thank you, Mr. Emeka.